Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features Dr. Susana Banerjee from the Royal Marsden NHS Foundation Trust in London and Dr. Mansoor Raza Mirza from Rigshospitalet Copenhagen University Hospital in Copenhagen. They will be discussing their choices of studies of interest for ovarian and cervical cancer presented at the 2022 IGCS Global Meeting. This episode is part of a larger educational program entitled 2022 Global Conference Coverage, an update on the clinical development across gynecologic malignancies. For more information on the experts, along with a link to the complete program, including a downloadable slide set and clinical commentaries, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
Hello, my name is Susana Banerjee. I'm a consultant medical oncologist and clinical research lead of the gynecology unit at the Royal Marsden NHS Foundation Trust in London, UK. I'm joined by Professor Mansoor Mirza, who is medical director and chief oncologist in the Department of Oncology at the Finsen Centre in Copenhagen University Hospital, Denmark. So welcome, Professor Mirza. So today we'll be highlighting for you key studies that were presented at the 2022 IGCS Annual Global Meeting in New York City and focusing on data informing our management of patients, specifically in cervical and ovarian cancers. And also, I'd like to talk about how it can shape how we interpret and how we design clinical trials in the future. So I would like to start with the CALLA trial. CALLA is the first global phase 3 study evaluating immune checkpoint inhibition versus placebo in combination with and following chemoradiation in locally advanced cervical carcinoma. So we know that chemoradiation has been the standard of care for over 20 years in this setting, and immunotherapy, PD-1 inhibitors, have shown activity in advanced and recurrent cervical carcinoma, and therefore a logical step was to take this early on in cervical cancer to see if we can actually cure more patients. So in this study, women with newly diagnosed, untreated, locally advanced cervical carcinoma were randomized to durvalumab or placebo for a total of up to 24 months, and that was in combination with and following chemoradiotherapy. So the chemoradiation was weekly cisplatin with external beam radiotherapy and brachytherapy. So 770 patients were randomized across 120 sites in 15 countries. Now, disappointingly, the durvalumab and chemoradiation arm didn't show a statistically significant improvement in progression-free survival compared to the placebo arm. The hazard ratio was 0.84. Now, so far, there's no detriment to overall survival, but the data is immature and not formally tested. So it's really important that we await results from other studies in this setting, for example, with pembrolizumab in the Keynote study. And I very much hope that we will see more trials addressing this important area of how we can improve outcomes, whether it be with immunotherapy combinations or other novel agents in the future.
And CALLA trial was designed to look at the locally advanced disease. These patients from stage 1B2 to stage 4A, these patients receive chemoradiation. That's the standard of care. And the idea was to choose the high-risk population out of that and treat them with chemoradiation and add concurrent to chemoradiation durvalumab or placebo, which is a PD-L1, and continue durvalumab or placebo as maintenance therapy. And the primary endpoint was PFS in this at 3 years. The trial ended up in a negative trial. It did not show any benefit of adding durvalumab, and it did not show any benefit of overall survival, although the events for PFS were only about 1/3, and for OS are even less, about 10-15%, which is very low. And it's difficult to say that these are the end results we see. So I believe that we will see some follow-up when you have higher number of events available, if it is giving any signal. But what was the issue with this trial? Why this trial was negative while other trials were positive? And that could be several reasons. One of the reasons could be that the definition of high-risk disease was probably not appropriate. That was according to if you had stage 1B to 2B disease, it had to be node positive. So just one node on scan would qualify a patient to so-called node positive, and which we know that it may not be true. So I think that is the major. Second issue is the sample size, which is not very large. That means that if we want to do the subgroup analysis of really high risk group, node positive patients, it would be difficult because the numbers are too small. So that's another setback we see. The third setback could be that the patients were given durvalumab both as concomitant and as maintenance. And one can discuss, was it necessary to give concomitant checkpoint inhibitor? You can both talk for it or against it. There is a biology which may say that chemoradiation enhances the efficacy of checkpoint inhibitors, and there is also biological rationale saying that it actually prohibits the action of checkpoints inhibitors. So probably we are missing an arm, which was maintenance therapy alone. All in all, a small trial, difficult to do subgroup analysis, and even more that the data cutoff was as such that only 1/3 of the events were available for PFS. So I believe that these were some of the major factors why I would call that this was a negative trial, and we have to wait for NGOT-CX11 trial, where there is a larger population, and that's a PD-1, not PD-L1, pembrolizumab being used. But we have to wait for more than a year to see the results of that trial. And even more important, the CX11 trial, the primary endpoints are both PFS and OS. So we have to wait to see if we can change practice and improve management of our patients in the locally advanced cervical cancer.
The next study I'd like to mention is a retrospective study in a very rare, difficult to treat cancer. That's the neuroendocrine cervical cancers. This disease has limited options, as we know, in clinical practice, a standard of care, but also very few clinical trials that include specifically cohorts with this particular type of cancer. So the NeCTuR study evaluated an international tumour registry, which was maintained at the MD Anderson, of outcomes of the combination of topotecan, paclitaxel and bevacizumab, which was termed TPB, versus non-TPB regimens in women with high-grade neuroendocrine cervical cancer. So this is a retrospective study. There were 62 patients on the topotecan, paclitaxel and bevacizumab cohort and 56 in the non-TPB arm. And interestingly, the non-TPB regimens also included patients on those drugs individually, but not the triplet combination. So the progression-free survival in the topotecan, paclitaxel and bevacizumab arm was 8.7 months versus 3.7 months in the non-TPB arm, and that hazard ratio was 0.27. So in this retrospective series, no difference has been seen in overall survival. The authors conclude that topotecan, paclitaxel with bevacizumab should be considered an option for recurrent high-grade neuroendocrine cervical cancer. Now, I think the results are of interest. It really raises the need and the possibility of prospective trials in this rare cancer. And we know that although trials in rare cancers, rare gynecological cancers, are a challenge to recruit, but as a gynecology community worldwide through international collaborations, we have shown that it's possible to recruit to rare cancers. And I think this is the time now to think about clinical trials specifically for women with neuroendocrine cervical carcinoma. So I'd also like to mention presentation at IGCS of overall survival by number of prior lines of chemotherapy in patients with BRCA mutated platinum-sensitive relapsed ovarian cancer in the SOLO-3 study, so women receiving olaparib treatment or non-platinum chemotherapy. Now, SOLO3 has been presented previously, but I found it very interesting, some of the subgroup analyses here. What I wanted to highlight was that in this post-hoc subgroup analysis, there was a numerically favourable overall survival in patients with 2 prior lines of chemotherapy, but there was a potential detrimental effect in patients with 3 or more prior lines of chemotherapy. Interestingly, a favourable progression-free survival was observed regardless of whether patients had received 2 or 3 or more prior lines of therapy. So how can this be? What are the potential mechanisms? And an important area of research is looking at secondary BRCA reversion mutations, which is a mechanism of PARP inhibitor resistance. And we know that that mechanism can be shared with platinum resistance as well. So in SOLO3, in patients who received olaparib, secondary BRCA reversion mutations were detected in 22% of patients at disease progression. And this may lead to resistance to subsequent platinum-based chemotherapy. So we need further work to explore whether BRCA reversions acquired in patients receiving olaparib, or indeed other PARP inhibitors, may impact clinical outcomes on subsequent treatment and therefore overall survival. And I think this is really important. We're going to hear about ARIEL3 from Professor Mirza, and I think this is a really important area as we learn more about the long-term overall survival effects of PARP inhibitors.
If you all remember, this trial was presented quite some time ago in 2017 by Dr. Coleman with their primary endpoint of PFS, which showed very positive results. And this time at IGCS, we saw that the overall survival data of this trial. So the trial design was that patients who had platinum-sensitive relapse and had received 4 to 6 cycles of chemotherapy, they were upon response randomized to receive rucaparib or placebo as maintenance therapy until progression of disease. They were stratified according to the HRD test, which was done by LOH, and other factors. So when we look at the results, the progression-free survival was very positive in all subpopulations, starting from the BRCA mute, in the BRCA wild type, in the LOH positive and LOH negative disease. And when we look at the OS data, just to remind you that the trial was not powered for OS, and alpha was not allotted. So these are results which are non-analytical. They can only generate a hypothesis, but you cannot change your practice according on these results. So when you look at the overall survival, you see in all 3 subcohorts, the BRCA mute cohort, the HR deficient cohort, and intention to treat population, none of them are significantly different from each other. Hazard ratios cross 1 in all 3 of them, and thus they are not conclusive. But as I said, this trial had a primary endpoint of PFS, which is extremely positive, and these results are non-analytical. So what we can draw conclusions from this trial, these results are that we have seen progression-free survival, quite a strong benefit. We have also seen that there was a lot of significant crossover in the patients who received placebo receiving PARP inhibitor. And as the trial was not powered for overall survival, we cannot conclude that this trial was negative or inconclusive. So I will not change my practice. I will keep on treating my patients with PARP inhibitors in platinum-sensitive disease as maintenance therapy.
So thank you again, Professor Mirza, for this great discussion. This concludes our discussion of the key studies presented at the 2022 IGCS Annual Global Meeting, which helps inform our current management of patients with cervical and ovarian cancers and clinical trials going forward. We hope you found this discussion helpful. Thank you for listening.
Thank you very much, Dr. Banerjee and Dr. Mirza, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, 2022 Global Conference coverage, an update on the clinical development across gynecologic malignancies, and to download a highlights slide set including the various studies associated with this discussion, please click on the link in the show notes. As always, thanks for listening.